Got 14 issues. Good afternoon, ma'am.
Hello.
Got 14 issues ranging from Medi-Cal to managed care to continuum of care reform to drug Medi-Cal. And we'll start with Medi-Cal caseload and estimate, page 47 of the agenda.
Sure. Thank you, Mary Cantwell, Department of Healthcare Services. So as noted in the agenda, we continue to see caseload growth in the Medi-Cal program. For 16-17, we're estimating an additional 700,000 individuals compared to January. So we are breaking the 14 million mark here in Medi-Cal and project 14.1 million in 16-17. In terms of the expenditures, general fund is down 1.4 billion. That's mainly due to the MCO tax, which is 1.1 million of that. And then some other items in terms of significant impact or just items of note. We are accounting for the cost of the minimum wage increase. We are now carrying in the Medi-Cal estimate the costs of the transition of the regional center consumers for behavioral health treatment. We also updated the number of eligibles we're projecting for the expansion of full scope benefits to all children, and so have an increase of 45 million in general fund for that. The NQI wrap is delayed until 2018, and so there's a loss of general fund savings there. And then finally, the other major item is related to the updated use of the federal upper limits for pharmacy drugs, and that's 130 million in general fund savings. So if there's other questions on that.
Questions? LAO?
Amber DG, Legislative Analyst Office. As indicated in the agenda, we reviewed the most recently available data on Medi-Cal caseload, and at this time, we find that the administration's caseload projections appear reasonable.
Finance? Do you think we've kind of hit the peak? Do we have is there?
I will never answer that because I've kept thinking we were gonna stop, but we haven't yet, so I refuse to answer.
Fair enough. Any public comment on this item? Seeing none, I will entertain a motion to approve. So moved. Please call the roll.
Mitchell?
Aye.
Monning? Aye. Stone?
No.
That's out 2-1.
No.
All right, issue number 2, Medi-Cal Federal Managed Care Regulations, Staffing Resources.
Sure, so CMS did release the final Medicaid managed care regulations on May 6th. This is a major overhaul of managed care regulations, really essentially impacting all aspects of it. Significant changes in oversight and monitoring, network adequacy, quality, rate setting, and program integrity. In addition, this request also reflects resources needed to implement the final regulation for fee-for-service monitoring that was published last November. In total, we're asking for 38 permanent positions in the department, as well as 2-year limited term expenditure authority for other work, really as an initial step to help us figure out all of the changes that we need to be doing over the next several years. In terms of the questions about the out-year costs, so given that the regulation impacts our managed care rate setting, we're still assessing what that really means for several of the financing structures that we have here in California in managed care. So the Department of Finance's out-year estimates of the budget do include some potential impacts of being unable to continue, at least at the same level, some of those financing structures that we have, particularly for our public hospitals. And as we've talked about here before, given that we have the AB 85 realignment redirection, any reduction in revenue to the public hospital systems end up being a general fund impact, because then there's less money being redirected under AB 85. And then finally, in terms of the last question, we haven't at this point identified statutory changes or other state regulation changes that will need to be made. That's certainly part of our work plan as we continue to work through the many pages of the regulations. We don't anticipate an immediate need that we see something right now, but certainly we will follow up as we continue to work through that.
And you'll provide the list to the committee once you've identified them. Great, thank you. Any questions, members? Senator Stone, none? LAO, please. Finance.
Thank you, Madam Chair. Senators Scott Ogus, Department of Finance.
We support the committee's proposed action to approve the resource request, as the department's going to need to get started on this work in fairly short order. However, we have yet to see the proposed trailer bill language referenced in the committee agenda, so we're unable to take a position on that at this time, but we are looking forward to working with committee staff to understand the intent of the trailer bill language and assess it further. Thank you.
Appreciate that. Public comment? Okay, seeing none, I will entertain a motion to approve and adopt placeholder trailer bill language, which includes a transition of care policy that ensures continued access to services while we transition from fee-for-service, and a beneficiary support system that performs outreach and assistance in understanding managed care.
So moved.
May I have a roll call, please?
Mitchell?
Aye.
Monning?
Aye.
Stone?
Thank you. That's out with a 2-1 vote. Issue 3, Medi-Cal managed care enrollment tax workload.
Sure, so first just wanted to note, I'm sure you all saw that yesterday we did receive official approval from CMS on the MCO tax. It was slightly modified, so over the 3 years, the amount to the state is down about $200 million, but we're still $3.8 billion, so generally still a very good impact and result for us, so excited about that. Our request...
Could you tell us the rationale around the reduction by $200 million?
Sure. So CMS requested that we make a modification to one of the exemptions that we had in the tax. We had an exemption for local community plans in Sacramento and San Diego. The exemption had been written that it excluded a Medi-Cal plan that was in San Diego. They took the position that it would not meet hold harmless requirements if we did not have a Medi-Cal plan included in the exemption. So we were able to expand that exemption under the authority given to us in the statute. And so that plan will not be subject to the tax. They were a Medi-Cal only plan, so the plan is neither harmed nor benefits from being exempted. It's just an overall change to the dollars for us.
Thank you.
Sure.
Appreciate that.
So the request here is for limited term authority to fund 2 positions for us to actually collect the tax and make the rate adjustments on the Medi-Cal plans.
And question number 2.
Oh, and I am deferring to, that's why I didn't have the answer.
Department of Finance. At this time, we're not in support of the trailer bill language, but we are open to discussing concerns of stakeholders.
Thank you. LAO? Colleagues? Seeing none, public comment.
Tam Ma with Health Access California, we strongly supported the passage of the MCO tax, are thrilled that it's been approved by the federal government, and support the department's request for resources to implement the MCO tax. We will withhold judgment on the proposal from HealthNet as we haven't seen it. Thank you.
Linda Way with Western Center on Law and Poverty. We also supported the MCO tax swap as it draws down over $1 billion in federal funds, and so do support the additional positions. Thanks.
Madam Chair and members, Dan Chick from HealthNet. We're kind of the fly in the ointment. Our tax counsel recently identified the problem outlined in the analysis. Essentially, when we passed the MCO tax, we failed to go back into the insurance code and adjust a provision that says for purposes of the GPT, the gross premiums tax, a carrier has to pay based upon what they paid in the prior year. So absent a fix to this problem, carriers will have to be paying both simultaneously the gross premiums tax as well as the MCO tax. And as a plan that was intimately involved in the development of the MCO tax, that was never envisioned, nor did we ever reserve for it, or did we plan to make such payments. In our case, it creates somewhat of a cash flow problem for us. In addition to the front end problem on year 1 of the MCO tax, absent a fix, we've created a problem on the final year if this was not to be sunsetted or extended. Our intent is to try to fix the both end, because on the back end, if we don't extend the tax in 2019, carriers would go a full year without paying any gross premiums tax, which I think would put the state in sort of a cash flow bind on that end. So that was our intent by bringing this forward. Again, we apologize for the lateness of it. Again, our tax counsel just discovered it, and we thank you very much for your consideration of this.
Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies. We represent the carriers that are regulated under the Department of Insurance and would ask that this item be held open in order to give us time to work with finance on a fix.
So I'll entertain a motion to go ahead and approve the 3-year limited term expenditure authority, the resources for the 3-year expenditure authority. Thank you. I'll call the roll for me.
Mitchell?
Aye.
Monning? Stone?
Thank you. That's out with a 2-1. Moving on to issue 4, electronic health records incentive program.
Good afternoon, Karen Johnson, Chief Deputy Director, Department of Healthcare Services. This proposal would authorize the department to allocate funds for this program, electronic health records program. Given the amount of growth that we have in this program, we need to allocate audit resources for oversight responsibilities and leverage the 90-10 federal dollars for this program. Today we have over 18,000 eligible professionals and 256 eligible hospitals that are participating, and we've allocated well over $1.2 billion, and we hope to allocate another $1 billion.
Questions from committee members? LAO, Finance, public comment. The motion has been made to adopt placeholder trailer bill language. Please call the roll.
Mitchell?
Aye.
Monning? Stone?
Thank you. That's out with a 3-0. Issue 5, covered outpatient drugs, final federal rule.
Sure. As noted in the final agenda, CMS issued the final regulation, another one, in February 1st. The rule on covered outpatient drugs addresses several key areas in Medicaid drug reimbursements. And so certain changes, as sort of I noted earlier, included the federal upper limits, which we have the savings already booked because those had to go into place this past April. Other changes, most notably to the way that dispensing fees are determined, need to be in place through a state plan change by April 1st of next year. So we're proposing this trailer bill to give us the ability to develop that, do the survey, and have those new dispensing fees in place in time for April 1st, as CMS has indicated there will not be extensions given to states to miss that deadline. In terms of the question about the concerns raised, we certainly again acknowledge that the implementation of the federal upper limits has resulted in decreases to the pharmacy industry. We would note that any change in dispensing fees would require a state plan amendment in order to receive federal funds. And given that under the rule, CMS has directed states to base any dispensing fee changes on a recent survey, which is what the trailer bill will allow us to do, we don't think it's at all likely that CMS would approve an intermediate change before we have that survey completed. And so we don't think that would receive CMS approval. So any change that might be adopted through the proposal from the industry before April of next year, when the rule must be implemented, we think would be very unlikely to receive federal funds and would be a state-only cost.
Members? Senator Stone.
Yeah, thank you for your presentation. I have some strong concerns about this with the federal direction. It's going to result in payments to pharmacies in the magnitude of $327 million, if I'm reading it correctly. In many cases, this formula may actually be paying pharmacies less than their cost for the acquisition cost for the drugs, and yet there's no commensurate increase in the dispensing fee. This is going to cause a ripple effect in pharmacies throughout the state of California, that many of whom, especially independent pharmacies, will work on basically $1.50 to fill a prescription. So how do we address that inequity, not only with the independent small pharmacies that are struggling to stay alive, but certainly the chain stores have some large exposure here that it's just not equitable that we decrease one without increasing the other to compensate.
Yeah, no, and totally understandable. I think our challenge is what we're limited to be able to do according to the federal government. Certainly, after we do the survey, whether that will result in increases or decreases to the dispensing fees, we don't know yet until we complete the survey for April 1 next year, but totally acknowledge the timing is challenging given that we had to implement the federal upper limits this past April and the dispensing fee changes won't happen until next April.
You opine that you're not going to get the results of the survey until April of 2017.
So we would get the results later this year in order to then develop the state plan, submit that to CMS, and have it be in place. It has to be in place by at the latest April 1st of next year.
So then we're going to go ahead and ask the pharmacies then statewide to absorb this subsidy, if you will. It's basically an unfunded mandate. We're telling them to fill prescriptions, lessen your cost, and we're not going to make you whole in increasing the dispensing fee. That to me sounds very, very unfair and unjust, and I think it will hear from some members of the industry that it's going to have some employment ramifications and may have some access ramifications, cutting back of hours. They're going to have to absorb $327 million somehow. I'd like to hear how they plan on doing that. If they can, I don't think they'll be able to.
Sure, and appreciate that. And again, all we would caution is that if there is a decision to do something, it would likely be 100% state funds because of the federal rules, but that's something we can't undo.
So it's something we can't undo as a result of the federal rules, but we also don't think we could get a CMS waiver in the process.
Right, CMS has been very clear that this is their direction and that states need to comply with this regulation and need to do it in time for April of next year.
Do you think access will be impacted at all?
But I'd have to go back to talk to our pharmacy folks to understand some of the sort of nuances of the costs and the issues with this. But certainly, we understand this is a big change and a big decrease. The federal upper limits are also things that will be updated every month. So how that will look and what will happen over several months and in the next year, I think is unknown at this time. But we can certainly bring back to the committee any concerns and information we have about access.
Senator Stone.
Just to follow up, is the source of the funds the issue with CMS? If the state were to come up with a subsidy, if you will, to ensure that a dispensing fee is going to carry them through until a year when the survey comes back, is the state prohibited from making any contributions to offset this hit?
No, so this using state-only money would be fine. We just would not receive a federal match.
Okay, then so to my colleagues, I think we'll hear from our speakers that this is a dramatic impact. And I would like to just state for the record, because I own a pharmacy, and I want to make it very clear that I don't take Medi-Cal insurance. So I want to make sure that there's no inference of any conflict of interest here. But I have strong concerns for independent pharmacies that do take Medi-Cal, and I want to make sure that areas that I serve, many of which are underserved areas, are not going to have pharmacies that are going to be impacted negatively, where they are going to maybe even not be in business if they depend solely on Medi-Cal for their existence. So I look forward to the speakers.
Appreciate that. Did I ask Elia? Finance? Public comment?
Good afternoon, Madam Chair and members. Brian Warren on behalf of the California Pharmacists Association. We represent individual pharmacists as well as the independent pharmacies throughout California. We're certainly sympathetic to the fact that DHCS is currently just implementing the federal law, and we have to work within the construct that federal law has given us. We do, which is why what we have proposed as amendments to this trailer bill language would provide a dispensing fee supplement only for drugs that are subject to this cut that took effect last month, and only until the time that the department updates the dispensing fee in 2017. And the rate that we are proposing for this dispensing fee supplement is actually tied to the 2007 cost of dispensing study that the department itself had acquired pursuant to legislation. So we do believe that this is something that, yes, it could be submitted as a SPA. SPAs are able to be implemented retroactively. And this is something that is actually supported by the department's own data as far as a rate that actually was appropriate. It is old, but this is something that we're supporting, and the age of the report actually is detrimental to us, if anything, but we feel that this is at least a fair compromise. This would not represent new spending, because what we're talking about is I guess, a reduction in the savings that the state would see as a result of these federal changes. But these are savings that the state never planned on having until the beginning of April when the federal government finally published these federal upper limits. Nobody even knew what this impact would be. So we see this as a fair compromise to ensure that pharmacies aren't forced to basically foot the bill for this timing issue in the next 1 year.
Madam Chair, for Mr. Warren.
Please.
Mr. Warren, thank you for your testimony. I just want to make sure that I understand your request on behalf of the organization. You're looking for a $3.56 supplement to the existing Medi-Cal dispensing fee to offset the decline in the ingredient cost. And it's your contention, and I think I agree with you, that it's a zero-sum game for the state because they're going to recognize the savings from the ingredient costs that are being supplanted by the pharmacies. And you're just suggesting that we go back to a 10-year-old study, basically. Certainly, it's probably, if we look at a contemporary study, it'd be much higher than $3.56, but the organization representing pharmacies is willing to compromise for this year until that survey comes back so that an appropriate fee would be implemented.
That's correct. And so what the $3.56 supplement would be in addition to the current dispensing fee of $7.25, which would bring us to $10.81, which is what that 2007 study did.
And that would be a state cost of $149 million that would be realized from the savings and the ingredient cost reductions.
Correct, which would only be a portion of the savings.
Thank you.
Thank you.
When would we realize? Next witness, please.
Jennifer Snyder on behalf of the National Association of Chain Drug Stores. We're supportive of the comments that Brian Warren with the California Pharmacists Association just stated. I'd just like to reemphasize a couple points, make sure that folks know that this is over a 30% decrease in funding for pharmacies. So it's a 32% cut overall to pharmacies. It'll impact over 70% of drugs that are dispensed in pharmacies. We would really like to have the department actually even ask CMS. I think we're making this assumption that that this is something that's just not going to be approved. This is, first of all, something that could be done with state-only money because we're only asking for half of the savings of the general fund savings to help us get through the next year. And as Brian Warren mentioned, it is a one-year fix. It's not a long-time fix, and it's something that CMS could approve, I think, if we actually ask them. So we would encourage the committee to look at amendments to this trailer bill to at least find some stopgap measure for these pharmacies for the next year. Thank you.
Angie Minetti with the California Retailers Association. Also want to echo the comments of my colleagues and are supportive of the amendments that we have proposed to increase the dispensing fee. I think it's unclear to us really what reasons are there for a SPA to be potentially rejected by CMS. I think we would ask the department still to simply submit the SPA at the very least. We believe that the data compiled based on the 2007 report for the dispensing fee is a modest ask, especially considering the time that the study was commissioned, and would also want to also raise the point that in April 2017, next year, CMS has, clearly contemplated an increase in the dispensing fee and has acknowledged that while there will be a decrease in the ingredient cost, that there needs to be some sort of equity made here in respect to the dispensing fee. So, I think we want to reiterate that this is very much a modest ask to sort of at least alleviate the impact for this year, and there will be a sunset. So would like to entertain the committee's consideration for that amendment. Thank you.
Peter Kellison on behalf of Walgreens. Walgreens is still in the process of assessing and analyzing the numbers as how this will affect their operations in California, but Walgreens is located in a number of rural areas of the state, is actively participating in providing service in underserved areas. There will be an impact from this. And, currently, and we support the comments previously made, this is really a timing issue. The reimbursement has been an accepted, relatively fair model. Now it's shifting because of the discrepancy in the timing to being an unfair model. We understand there are limitations as far as how to proceed. We're engaging DHCS staff on Friday. We hope to be able to provide some sort of progress for this so that there is, in fact, some remedy to address this issue on a stopgap temporary basis, and would look forward to your support for encouraging further progress on this issue.
Yeah, members of the committee, Kevin Pedrati representing CVS Health. I'll just concur with my colleagues on this issue and ask for your consideration. Thank you very much. What you